morning.
So what we have on our agenda this morning is amendments to S.203, and we have a specific amendment that I think we have projected and is available, posted on our website or on our web page from Representative Cooper and others, some of whom are members of this committee. So, good morning, Mary.
Morning.
Just for the record,
Yeah.
and then walk us through what you have.
Yeah. So good morning, Representative Mary Hooper from Montpelier. And what I have before you are 4 proposals of amendment to your bill, S.203. They really came out of a conversation when you were walking your bill through appropriations, and we were chatting about what it does. 3 of them I think are quite simple. So the first is simply changing the reader heading where it says, your bill said legislative intent, and oversight has been added so that in the second section where we add a request that the Secretary of Human Services report updates on what's going on with the renovations at the retreat and the planning process that's going on with UVM to develop the level 1 beds for mental health patients. So we just thought that there should be some, I'm proposing that there be some legislative oversight and a check back in that process. So that's kind of one idea there. Just tell us what you're doing. The next proposal of amendment is the third, which is at the bottom of the page and going on to the top. 1, 2, and 3 are what your committee said. 4 is what I'm suggesting be added, which is that if people aren't if the transport officers' departments are not in compliance, identify how you're going to come into compliance. And if they're still not in compliance, how are you going to replace those services? And that, quite frankly, comes from however many years of us saying, we think you ought to not transport people that way. We really mean that we think you shouldn't transport people that way. You ought to follow the law that we passed. Yes, we really mean you should follow the law. And so now it's kind of, darn it, do it this way. So that's what, I mean, it is out of a deep sense of frustration with the handful of people who continue to not seem to be able to follow the law.
And if I may, I believe there have also been conversations with the Department of Mental Health that a plan of correction is something that they would support. Yeah. As I think we had simply said
well, I
something a little.
Representative Hooper's, not ours, but Representative Hooper's first version of the amendment had said, tell us how you're going to replace the services.
Yeah.
And they responded saying, well, how about a plan of correction
first?
Yes. So I think this is just so folks know that this is embedded with this particular piece is embedded with the department.
It is somewhat of a compromise. Next year we're not compromising. And then the fourth one is where I'll probably need some help in adequately describing this, but in the fourth section proposal of amendment, I'm saying 2 things. It begins with recognizing the importance of the designated and specialized service agencies to our healthcare system and the important role that they play in preventing hospitalization and emergency room use. And then the substance of it is at the top of page 3, which suggests 2 things. One, initially, right now, use the same model that is being used to develop rates that you all have discussed for the Brattleboro retreat. Use that same model for looking at how the designated and specialized agencies should be funded, and provide that information to us as part of the budgeting process next year. It doesn't say build the budget based on that, and that is the budget. We're just getting the information. And I can say, as the person who's responsible for a portion of those budgets, I am totally out of my ken in being able to do any sort of analysis of their budgets. And we need some sort of other competent agency providing that sort of oversight, which is actually maybe more to the point of the second part of this amendment. But we need a better way of getting into what the DA budgets are. It's just beyond our ability to manage it the way it's running now. And that is then to the second one, which is to suggest that the process that is going on now include the work that should include an analysis of the mental health portions of the healthcare system, and that should be incorporated in that evaluation process with the long-term goal of bringing this underneath the Green Mountain Care Board. And so there are all sorts of interesting policy questions that we as a body will need to answer as that moves forward. But to the point that I was making, right now we don't have the capacity to do the sort of careful analysis of those budgets that they deserve to make sure that services are being properly delivered. We need help. We've had kind of different members have had informal conversations about how to accomplish that. And we keep seeming to come back to the Green Mountain Care Board. So I've brought us to the Green Mountain Care Board here. And I would really appreciate help in making this better. It sort of accomplishes what we think it ought to be doing.
Can you say again what you think the time frame is as you're talking about, particularly the review of budgets?
So it's a long-term time frame, and I believe that it would be a 5-year process. I think it's a 6-year process that we're engaged in now, and we're in what I have heard described as year 0 is kind of the planning, and then the rollout, I gather, is a 5-year process. And so I'm presuming that at the end of this, we would be, if this is the path we choose to go down, DAs and specialized service agencies and the delivery of these services would be under the regulatory oversight of the Green Mountain Care Board.
So I think there's some.
Okay, and can I just say, I should add, I sent copies of this to the Department of Mental Health and to my DA, just as a way of checking in with this amendment.
And
I haven't heard back, actually. I need to read my email.
Good of you to send it,
Yeah.
but-
No, I have nothing else to say.
Okay.
Yeah.
So if you'd like, Mary was asking for help. I did help work on some of this, and I can give a little bit of background on this section 1 and 2.
Okay. So let me say that, so we have some time here, and I understand there are some other folks that wish to be heard on your amendment, and it's important that we take the time to actually think through what implications there may be. I say this having put my name on the amendment. I put my name on the original amendment and said revisions. I'll be happy to sponsor as well. And this is a section that I think deserves a little more consideration. So I think the whole committee needs to be able to raise questions or to hear from others.
And if I may, in fairness to the others who put their names on the amendment, it grew, and we circulated it back to you, but it may have grown more than people had appreciated.
Right, and
So.
I think in the press of other people's attention to other issues, I'll speak for myself and probably others, seeing that there was a revised amendment did not necessarily capture the attention, saying there's some new elements that were not, that are substantial that weren't in the other. Yeah. Great, so I hope you could
I'll hang
maybe
with
stay.
you. Yes,
That'd be great.
thank you.
So,
I mean, this is a piece that probably people need to know in terms
Okay,
of
what are-
before
and then we'll-
testifying, so.
Yeah, then we'll come back to
Right,
Mike.
right.
Yeah, and then we'll hear from others.
Because there are two pieces here that, particularly the first one, that this committee has not heard a lot of background about, because I was sitting in on Senate Health and Welfare when they got their presentation from Aldo Bay. And I think he didn't go into that as much with us on this, how they're looking at the rate for the retreat. I'm not an accountant, so I'm not gonna use the right words, but he was basically explaining, and the retreat was explaining, that in order to, they've got staff that they can't hold on to because rates are better at hospitals and so forth. But in order to meet their needs of sustainability, the only way they can really address it is looking at their whole costs and their whole revenue and saying, this is the gap, and so we need rates that fill that gap. And there were questions raised about, isn't that the problem the DAs have? And the answer was, well, yes, but with them, we look at the individual services and what the rates need to be to reimburse those services. We wouldn't feel comfortable knowing that they were really addressing running tight budgets if we just said, tell us your total costs and tell us your total revenue. So we can't do it that way. And so members of Senate Health and Welfare, and in fact Senate Appropriations, asked, well, wait a minute, you're using a different standard. So the concept here was to take that and say, well, we think you ought to identify what it would mean if you looked at the DAs the same way that you are now presenting and asking the legislature for how you're addressing the retreat's sustainability. So that's where that comes from. That's what it means by saying the same model as the retreat. It's what's being presented this year to the legislature. And the second part, we heard just briefly from Michael Costa a few days ago about this Medicaid pathways, the all-payer waiver. One of the things it identifies is over the 5 years, there's supposed to be a pathway for all of the Medicaid services that are not Medicare Part A and B, therefore that are not in the all-payer starting waiver, that they're supposed to all end up integrated as part of the all-payer waiver. So this is something that's a work in progress. So that's the reference to the Medicaid pathways. That part of the plan, if you're really following what the goal is of the all-payer model, is that the budget review process would come under the same board that's doing ACO reviews and hospital budget reviews. They can't actually approve budgets because that's a legislative function because of the Medicaid money, but they can review, and they've had a trial run of that with the Howard Center a few years ago. They were asked by the legislature to just do a kind of sample review. So that's the idea behind that one. That's what that means by saying, and that's what talking about it being not something next year, because this is a process as part of the all-payer waiver.
Can I just say, I'm not sure that's clear.
Is it
In the
could be.
language of in the language of rather, I think one could conclude that this is an immediate additional responsibility of the Green Health Care
And
Board.
that it's gonna happen, as opposed to needing legislative action at some point down the line to transfer the responsibility. Right, it could be some wording
I
where.
think there's some work needs to be done.
Yeah, not too long ago, we addressed the financial situation of DAs by legislation and doing some pay adjustments, stuff like that. Do you know what the current financial situation is for the DAs, how this would impact them? I mean, wasn't that long ago. How much of a change has that made? Has it changed the situation at all?
So we, invested, I think it was less than $9 million, or as much as $9 million, 8 point something in the system last year, so which comes into the current fiscal year. And that was to raise everybody's rates to $14 an hour. And if that wasn't enough, we said focus on emergency services. I understand that, in fact, they were able to raise rates pretty much across the board to $14 an hour. It did not go further than just that. And you may recall that last year when we invested that money, we also asked that the Agency of Human Services report back to us on the additional investments that would be necessary to accomplish essentially the stabilization of the system. And we received a report back that said, we really, perhaps I'm being unfair in my synopsis, but they essentially said, we can't tell you what that number is. There's a lot of different things that we need to take into consideration. I need to look it up, but I believe there was supplemental information that was provided as part of that report that said something on the order of maybe $70 million was necessary to bring everything up to deal with wage compression and, bring the care providers in that system up to, I don't know if it was the hospital levels of pay, but their peers within the private system. So we didn't address that bigger issue.
Can I just add, I think a piece of what I'm remembering from what we did last time was that what the 8.37 million that was put in was considered to be stage one of what was then hoped for and intended to be stage two. Stage two is not reflected in the appropriations in the budget of the House at this point.
And the other thing, and probably the chair is here, so it's maybe a question to him. What I've noticed is whenever we bump into a situation in healthcare, we're always quick to say, let's put it to the Vermont Care Board. I'm not sure how much capacity or more capacity the board has. Why would we not look at AHS to look at this?
I would suggest that there is a need for an independent review of that. Right now, we are the check and the balance of that system between the legislature and the executive. We do not have the staff to do that sort of analysis. So I was looking around for who the other people are who are independent of the system. The administration has a position that the Secretary of the Agency of Human Services supports, and part of that has to do with funding goals. And so there's not an ability for that body to really dig in and report back to us on what the actual needs are of the system when you're dealing with that political imperative, which is certainly their prerogative. I'm not questioning that. It's more of this desire to have an independent third body that can look at it. And if we were properly staffed to provide that service, I would say that's our job and that's the way we're organized, but we're not there.
I guess I have a lot more questions, not quite convinced that we need this particular section.
Okay.
Thank you.
Yeah.
So I was just gonna say, in our bill, already, we had a section of the report back from the agency to next year saying, make recommendations for how we can be dealing with these budgets as part of the healthcare system, as in, the way that we deal with other healthcare system, the hospital and so forth. This would go a little step beyond that, because we're saying bring back recommendations in our bill, and this is saying start working on a plan.
Okay.
So maybe I missed something, but I know that Green Mountain Care Board reviewed Howard Center budget a couple years ago, and I'd be interested in hearing more whether all DAs are really interested in submitting themselves to this process, because I know it's quite a rigorous process in other facets of budget review, and I think that's something to keep in account, especially since a big part of the hospital budget review is to keep costs down, and really put some downward pressure on the rise of these hospital budgets. And here, I think nobody would say that DA budgets are growing particularly fast, and that's the opposite problem. So
They've said, we would love to have the same rate of growth that the hospitals are squeezed down to.
Right.
Yeah, well, and I might say that, I think, as I've reflected on this just over the course of this half of the biennium and longer, but particularly in this half of the biennium, we just, in our larger bill, we are embedding in other statutory references, references to ensure that we actually follow through on our commitment to parity of mental health as a part of healthcare. And I think that increasingly, when we have the Green Mountain Care Board looking at a portion of healthcare and if we really think about healthcare, then it increasingly makes sense for us to be thinking about the Green Mountain Care Board having that ability to actually look at all of healthcare, because we're continuing to segregate mental health from healthcare, and I think we do have a responsibility to look at whether the resources, is there a time frame in which that could be accomplished, et cetera. And I think, Ben, your point is right on point, because in fact, when my recollection was from the previous chair of the Green Mountain Care Board, now Secretary Gobet, was testified here that they were stunned to discover on what how narrow, what a shoestring they were operating on, that they were used to seeing X number of days of cash on hand, X amount of reserves,
Yeah.
and suddenly realizing that there's nothing close to that in the system that is an essential part of the healthcare system in the state of Vermont. And so I think the dynamic might very well be a different dynamic when you actually get to see the entirety of the picture. But I think you're
Right. All I was trying to say is there's a fundamental difference in the role as opposed to cost containment versus more appropriation, which comes through the legislature.
Well, I think their role is also to have a sustained system and not just to do cost containment. So it's like to have an effectively appropriate system. But
Mhm.
cost containment is absolutely a piece of that. And so I'm going to, so maybe in response to your question, and then I understand there are others who wish to be heard. We're going to have to figure out how to manage our time, but we have some more time. So Julie Tessler is here from Care Partners, which represents the designated agencies, or is a collaboration or consortium of the designated agencies. Perhaps you could respond to the question which Representative Chickling just posed, particularly about what position, what would the DAs, either as a group, if there is a position, respond to the idea of having the Green Mountain Care Board review DA budgets?
We would-
Well, it's DAs and specialized service agencies, which are not one and the same.
Thank you for the opportunity to speak. So Julie Tessler, Vermont Care Partners. We haven't had discussions with the Green Mountain Care Board about it, so it's a little hard to speak about that without having had the discussion. But yes, we have definitely talked about the value of having the Green Mountain Care Board review our budgets. And for all those same reasons that have been raised, that we really feel like our budgets are very tight, that we're part of the healthcare system, we should be looked at as part of it. The all-payer model does lead us on a path to be a more integrated part of the healthcare system. And in the interim, we've gone to the Secretary of Human Services and said, including the business manager at the Howard Center who went through the analysis and said, at least let's start with an interim process that looks just like it. You should be doing the same review and understanding our budgets in the same way on an annual basis. So when we sign our master grant and we say we're getting this money to do that, you know what we're spending the money on, where our costs are increasing, review our key performance indicators of where we are financially, what cash on hand, our debt equity ratios, things like that. And then let's look at what we can do. How many people can we serve? What's the scope of services? What are the outcomes and expectations that are reasonable with the budgets you've given us? So we brought that proposal to the Secretary, and we're working on that. So it's a work in progress. And the Senate Health and Welfare said, please come up with some language for this section. So we've started that conversation with him. I emailed him at 7 o'clock this morning, language. I said, can I share this? And he said, not till I look at it. So, but basically it says, please look at all this. Please work with us on it. Make this part of our annual process. We want to be transparent, accountable, and we want them to understand that if we don't get increases, we can't keep providing the same level of service we've been providing, because we are over $70 million short of what we really need for staffing. So how do we set reasonable expectations? And I really appreciate the work of this committee to say it's our intent to invest in the community mental health system, because that's going to make a difference in healthcare, and it's part of what we do. My understanding from my conversations with the secretary is that he's not sure there is a will to make those investments, and we have a capped budget and tough decisions have to be made. And as the House did not put money in for workforce, I can't fully argue with his perspective that maybe the will's not there to make the greater investments. But it is interesting to me that we put there's been a lot of discussion about prevention and health promotion and the importance of that. And that's in part of what community mental health does. It meets people's needs immediately at the community level, in schools and communities. So it's hard to see an investment, making investments in the symptoms and the acute care when we could be doing more up front. So we are definitely open to better analysis, because we feel like we're really at the edge. And part of it we take responsibility for when we don't get increases. We haven't been saying, sorry, without some kind of inflation, we can't continue to do the same level of work. We somehow suck it up, and do that. But we're at that edge. We can't step back anymore. So.
And I think we have actually articulated in language last year, which was not acted on, which was saying that rates shall be established, and if they cannot be established, then work that needs to be identified, which is no longer going to be required.
Yes.
And I think this is another way for us to, I think, be on the same page of saying it's not reasonable to not increase rates and increase adequate funding and have the same level of expectations, as hard as those decisions may be.
Absolutely, and we really appreciate the legislature's involvement, in this committee in particular, in raising the issues, and feel like that's added balance to the picture as we move forward in making funding decisions.
So, Mike,
Yeah.
is this a question for the witness, or is
Yes,
this?
yes, eventually. I think budgets in general are tight, whether you talk hospitals or whatever, and staff shortages exist in the DAs and in the hospitals. But one thing that you said, the lack of will, I'm not sure if it's so much a lack of will to do the funding, it is the ability of finding those funds and resources. But my question is, what, over the last 5 years, what is the rate of growth for DAs?
Well, if you could separate caseload from inflation, I think that's really important, because in developmental disability, there's a growing population, and it grows by about 8 million a year. So and we're about a $400 million system of care. So if you look at both caseload and inflation, you would probably get to 3% or something close to it. But if you take that new caseload out, we've actually had rescissions and some increases. So I can't do it off the top of my head, but it's been very minimal. And even last year with that workforce investment, $8 million is a lot of money. But over a $400 million system, it ended up to be 2.1%, and it was very targeted. State employees got greater pay raises, and there were health benefits, and there were other things covered, like IT systems. So out of that 2.1, we actually had to do more. And so it kept us afloat, and it certainly helped our lower paid staff. And we can say, yes, raising a minimum wage really helps those staff a lot and helped with recruitment and retention. But our gaps with the other staff actually grew, so that you can go to DCF and earn over $20,000 more than the same job in a designated agency. And so most of our staff, when they're walking out the door and we say, why are you leaving? The majority will say, because I really can't afford to work here. I've been working 2 or 3 jobs. I can't handle it anymore. I can do similar work and earn better pay in other forums, whether it's state employment or a hospital or a school or other places. Most of our staff love their jobs and want to stay, but it's tough work to have to do 2 or 3 jobs to maintain it.
So we're not going to be able to get into the depth of this morning. This is to look at what the amendment and whether or not this is the language to move forward specifically in this amendment. I'd like to turn to, if there's a comment that the Green Mountain Care Board wishes to weigh in since you're referenced in the amendment.
For the record, Kevin Mullen, Chair of the Green Mountain Care Board. And basically, we have more questions than comments. Basically, I understand the theory behind this, and I think that those that were involved in the look at the Howard Center felt it was a productive use of time. Wearing my former legislative hat, I have to ask, similar to the questioning that was put in place earlier, in that in hospital budgets, we actually control the rates. So I would hate to see an extensive process set up where we would go through and analyze all these agencies, and then notwithstanding, things just carried on in the same manner in terms of their funding. So that's something you have to look in the mirror on. I would just say, but if the point is that there wouldn't be any changes in the funding, I think it would be a terrible waste of our resources to go through that process. And I will say that, and I listened to your argument, Mr. Chair, and it's very consistent with what people talk about what a global budget should contain, and it really is the whole host of things. So in this conversation, I want to throw out that, for example, in home health, we have a hospital in one part of the state that had to meet the payroll for the home health agency strictly because Choices for Care, a state program, isn't funded in a way that they can sustain themselves. So I think you may be opening the door to other things in the future, but as far as this particular amendment, it really is just a reference to AHS doing an analysis of whether or not we should do it. So, I don't have too much comment there, but one question I would have for Julie is everybody on the same fiscal year? And if so, what is that fiscal year?
We're on a July 1 fiscal year, but there's discussion in payment reform of putting us in the same calendar year as the all-payer model ACO, so that we would be consistent.
So either one of those would be a slightly different fiscal year than the hospital budgets, which is a good thing, because if we had to do everything all at once, forget about it. You'd have to give us quite a bit more staff, but if it could be staggered a little bit, and it sounds like either one of those could be. So it really is just questions for you.
There are many things that would need to be worked out before this
Right.
This does not implement. I mean, I think that,
Right.
to be clear, but this is, and that was my concern, to be honest, when I first saw the new amendment. I was immediately concerned, has the Green Mountain Care Board been consulted about this?
The answer is no.
Well, I'm just saying, so that, and part of what needs to happen is that I needed some assurance that there was not an immediate impact, and that it's more looking ahead, with lots of opportunity both for the legislature to weigh in further, and for the Green Mountain Care Board to weigh in further, as well as the Agency of Human Services.
At a minimum, the word plan probably needs to be proposal.
Yeah, so,
Develop a proposal.
So I think everybody's on the same page.
yeah, okay,
Thank you.
thank you, Tim. Okay, so I'm going to suggest that we have this, so S.203 is on the floor this afternoon. There's time between now and there's time between now and then for any language to be modified. I think there's a very least, there's some language modification that could clarify what it is that's been articulated here. And I think, there's Mary's looking for, so I'm going to suggest this, that this committee not try to take any action on Representative Hooper's amendment at this time, but that we ask that you and perhaps Representative Donahue and others review the language to see if there isn't a way to make it more clear that this is
Clear, the intent clear.
the intent clear, that there's not an immediacy involved, other than to be looking ahead and planning, or that in fact I'll just throw out from one member's point of view, maybe there is some piece where there is actually submitting of information for informational purposes only and not necessarily for analysis, because I could imagine either as part of this plan, I should maybe not overstep what their plan might be, but there could be submissions on an informational basis that don't require a lot of additional staff work from the Green Mountain Care Board, but that would in fact begin the process of providing the designated specialized service agencies information to the Green
So
Mountain
they
Care Board.
have that holistic system view.
Because
Yeah.
I'll tell you, I'm more and more persuaded and understand what the chair of the board has said, that until and unless we have a full picture of what we're talking about in terms of the healthcare system, we're really, we're wrongly focusing on just a significant portion, but not the entirety of the system. And I think we need to, if we're going to be serious about working with the entire system, regulating the system, sustaining the whole system, because it's not just downward costs. It may be downward costs in one part of the system, and it may actually have to be holding another part of the system whole. I think we need to be moving ourselves in that direction. Speaking for myself. So, if that seems agreeable to our committee, I'm looking around and seeing some and I would welcome any committee member to weigh in with Representative Hooper in terms of seeing if there's language that my hope would be that we would find language that certainly the majority of us, if we don't, we won't support the amendment, but I would hope that we can have language which goes in this direction, but that's more precise. Okay, so let's put that piece to a close for this moment, and then we'll come back to it. We're going to need to come back to it before the floor, and I think we arranged. Well, we will come back to it before the floor. Yes, we have to, because that's what we're going to do. Or we'll rearrange the floor if necessary. That's also possible.
Plenty of room tonight.
There are. Okay, so let's shift gears. We have a number of other things on our agenda this morning. I think I'm going to turn to. Do not see Nolan in the room.
No, I told him I'd alert him when you were ready.
Okay, we're ready. Okay, what we're going to do is I want the committee to hear the Senate proposals of amendment to number 696. Okay, so let's just I'd ask the committee members actually to stay put. So thank you for waiting. I got my wires crossed a little bit in terms of what we were doing when, and so it's important. It's important for us to have everyone present for our committee discussion, and I think what will be a likely vote today on a very important issue. So what we have in front of us today is S.53 as it's come from the Senate. And as we've taken testimony, we've walked through from the beginning. I said to the committee, I want us to understand both what the Senate has sent to us, and I want us to understand what the Senate Health and Welfare Committee passed out of the Senate Health and Welfare Committee as well. And so we've had the opportunity to walk through S.53 as passed by the Senate, S.53 as it's come out of the Senate Health and Welfare Committee. And there are differences that are significant. S.53 as passed by the Senate features a more of a continued exploration or study of universal access to primary care. while S.53, the Senate Health and Welfare, makes a commitment to publicly finance universal primary care. And I think that's, in some ways, the crux of the issue in front of us. We've heard the fiscal impacts of both pieces of legislation, and quite honestly, I think it's a little unclear. I don't think either of the fiscal analyses are complete, and so whatever action this committee chooses to take will necessarily go to the House Appropriations Committee. That's a foregone conclusion, and we will be looking to them to sort through issues, fiscal issues, but particularly the impact in the 2019 budget, which of course, because of the way the Senate and the House, we moved the budget first, so we assume that the Senate is anticipating, based on as they passed it, having provisions in the Senate proposed budget in response. We'll have a provision for that, but we recognize that there's nothing in the House budget to support either version. So again, there are many moving parts here. And I think we've heard from many. I mean, to be quite honest, I don't know everyone who's in the room, but I recognize numbers of you, and I've heard from, and I think many of us have heard from folks who are in the room. We've heard, I certainly have heard, and I think the whole committee has heard from strong voices of advocacy asking us to consider not just the Senate passed version, but to consider reinstating the Senate Health and Welfare Committee's version. And so I think that's the choice point we're at. And I think that we need, as a committee, we could have long debates. I concluded, I think we're at the point where we need to decide in order to move forward. And so that's where I think we are at this point. Brian?
Yeah, your hand up too. No. Okay. Well, I'd like to make a motion. I'd like to make a motion that we restore the language of S.53 to the version that came out of Senate Health and Welfare.
I'll second.
Okay. So we have a motion to restore, which essentially would be to substitute.
Yes.
To substitute a strike-all version for the Senate passed version. Okay,
Yeah.
to restore what the Senate Health and Welfare Committee did. Okay, and we have a second for that. Okay. Would you like to
Can I explain?
Speak to your motion?
Yeah.
And then have Representative Don.
So, Senate Health and Welfare, which is the Healthcare Policy Committee of the Senate, worked on this bill for over a year with extensive testimony and deliberation, and they created a proposal that looks at how we can make a transition from our current system towards the vision of Act 48 through a process that engages various stakeholders in the creation of a universal publicly financed primary care system for all Vermonters. The result of that work was replaced by an amendment from Appropriations in the Senate, which is their money committee, and that ultimately passed the Senate. And I think policy committees should be making policy, not money committees. And I propose that we support the work of our sibling policy committee, Senate Health and Welfare. Whether or not this bill survives the rest of the process and becomes a law, I think today we need to make a decision that makes a policy statement. And what statement should we make? I propose that we take a step in the direction of the promise of Act 48 by restoring the language of the bill to the version that came out of Senate Health and Welfare.
Yeah. Representative Donahue.
So I actually think there's tremendous value to an approach to curbing healthcare costs that starts by ensuring everyone can get early intervention that can prevent higher cost healthcare later. And particularly by doing it across the system, not through small inequitable chipping away at co-pays for specific services. It would also start us on a path to more equitable access to healthcare, regardless of what coverage you do or don't get from your job, which is something I have consistently, strongly supported in concept, not always as a practical ability to do it. because while almost all Vermonters have health insurance, it's an incredibly inequitable cost balance. The very poor through Medicaid, and the very wealthy through a very small percentage of their income going towards healthcare, pay relatively little or nothing, but we know very well that there are people in the middle who have incredibly high premiums and co-pays that are a barrier to care. The problem is that for better or for worse, we've embarked on a healthcare reform initiative right now that makes huge alterations to how money flows through the system. I supported that very reluctantly. I remain not confident about its potential for success, but it's very complex. It creates huge pressures on the system in order to focus and sustain energy on it. To take on a second major overlapping restructuring at the same time, I think does doom both to potential failure. And so I can't support going forward with this, either version, even just studying it further at this particular point in time. I don't think we can be doing both at once. So I don't support going forward with either approach for that.
Sarah?
So I thank you, Brian, for your motion, and I'm going to support your motion. You know, I've been sitting in this committee for a number of years, and have now, this will be our third attempt at enacting some form of universal health care. And I have to say, it's really frustrating to be in the position of considering this kind of incremental approach as opposed to taking on the whole healthcare system. But I am critically aware that there are so many Vermonters who either are paying through the nose for the healthcare that they have, or are stuck in jobs that they would rather not be in because it provides them with a healthcare benefit. And I feel like we owe it to Vermonters to say that, yes, we want to move forward with finding a way to do a universal healthcare coverage. So I will support your motion.
The Senate Finance Committee took a look at the finances of this, and it came to the conclusion that with 20% of the entire state spend being on healthcare, that we had to move a little more slowly, a little bit more pragmatically. And I don't think the original version took into consideration all the money that it would take. I've heard even among our testimony, the cost for this would vary between 4%, we were initially told, and by the time we were even done deliberating on this, it was already up to 7 or 8% of the entire healthcare spend. So I don't think this is really well thought through, and it doesn't get to the root of the problem of healthcare. And the root of the problem has more to do with a socialized aspect of healthcare in this, that it's very expensive. Although I agree everyone should have healthcare, we live in a very free country, and I think that we should be promoting avenues that that compete against one another. Right now, we have quite a few monopolies within the state, whether it be one ACO or 2 hospitals running the entire state. Very few private practices left, and we've created this monopoly. We have only 2 insurance companies, and I think we can go down a different route, which will create more competition, not less.
I wasn't going to say anything, but listening to everyone, this has been one of the most difficult decisions I've had to make. I agree with Sarah and Brian wholeheartedly. I come from a family, we have a small business, we have a healthcare crisis in our family that we'll be paying for the rest of our lives. So I see this both sides of having a universally publicly financed system. But at the same time, I really appreciate Ann's words in that the state made a commitment for a process forward. And we have some people in this room and many, many other people who are putting everything they have into making that system work. And to put another system change on top of that is very, very difficult. The other thing I've struggled with the last 2 years here is we chip away at everything instead of changing a whole thing. And so I will be supporting Brian's motion because this is one time where we need to chip away and we need to figure out how to do it.
I also support the motion, and I do hear the viewpoint where we are doing one thing and we can't do two things, we can't look at both. I think we need to look at both, because if the all-payer model doesn't work, what will we have in its place? And we need to, the people of Vermont need health care. And when I think about the all-payer model, it comes from the hospitals down to the primary care and the funding flow. Whereas I believe that the funding flow needs to start at the base, and primary care is the base, and it feeds up to the hospitals. And by doing that, all those components of, are you ill now? I can't afford it now, so I'm going to wait. And you're much worse at the time you do seek the care. Are the pieces that drive the healthcare costs that much further? And by allowing everyone to go in and see a primary care, I do believe that we may find there's an uptick in the costs at the primary level, only because those people that have been resistant or unable to access the care will have issues that are more extensive initially. But going forward, I think we take that away, and by treating it at the preventative level where it belongs, we prevent those long-term higher costs that we have when people don't have care. And so that's why I support this.
I'm going to support Brian's motion, and thank you for making it. When I was elected in 2014, the primary issue that I ran on was trying to move our state to a publicly funded universal care system. And I don't think I'd even taken office yet when that option kind of got pulled off the table in Vermont. And acknowledging Lori's frustrations, I think we are going at this in an incremental way. And I view this as the most cost-effective way to go at this in an incremental way, where our healthcare dollars are most cost-effectively deployed, making sure that people have adequate primary care. And I also want to acknowledge Ann's points, because there are things that I'm concerned about as well. But I am going to take a little different twist on it, because while I'm concerned about the issue of can our state take on a major reform effort of the all-payer model while simultaneously taking a look at universal primary care, a concern that I have about the all-payer model is I feel all our eggs are in that basket. We are depending on the all-payer model to work to get to what I want to get to at the end of the day, which is a publicly financed universal care model. And I'm looking for different baskets instead of just having that one basket with all the eggs in it. And an incremental approach of moving down the universal primary care road gives us an additional way to approach that. So thanks for making the motion.
Well, our mantra, this has been, it has not been a hard one for me, because our mantra has always been with the health care. It's the right care at the right place at the right time. Right care, I think this is the right care. I do believe this is, you just see all the people in need out there, and you know this is the right care. The right place, if there's any place that's gonna do it, it's gonna be Vermont. Except in my heart, I really know that we need a larger platform. If it's going to be publicly financed, it would have to be nationwide or even regionally. The right time, this is definitely not the right time for Vermont. We have two major health reform efforts that will be going, which would doom both, and we would get nowhere. Or the all-payer ACO model is basically a little more than its first year. To layer something else as complex as this on it is just not the right time. It would just, Vermont is, even though it's hard to believe with all we get done in Vermont, Vermont is a small state, and there's only so much money and so many resources to go around. Basically, on the right time, I'm gonna be voting against this bill.
Not everyone has to speak. Anyone else wish to speak?
I guess I might as well if everybody else does. You know, the only thing I would say is I would be much more likely to support the Senate finance version, just because I think it does a better job of distilling what the problem we're trying to solve is, and then taking a broader look at is the best way to get people the access that they need. You know, we've heard from people throughout the system that there is an access problem. We're dealing with a certain amount of, certain segment of our population that either for financial, they can't afford a copay, or they're uninsured, they're having trouble with getting the base level of primary care that I think we all believe we should do everything we can to try to get them there. So I would have much preferred an approach where we take a holistic look at saying, we have this set population that we're not doing a good job of now, how do we connect them, and are there different, different types of innovative ways that we could look at to really reduce, this problem of access that we're seeing?
Generally, have a practice everyone speaking first before others speak second, so come up the mic.
Well, we may as well. We have something to say. Well, quite honestly, I think many of us are working with the local hospitals on the crisis in primary care practitioners. I know in the Brattleboro area, we're down 13 practitioners, and we've got another one retiring. So, to take on a primary care initiative without having the underpinning support, I think is extremely difficult to do. And I also agree with Ann on the parts of trying to operate two systems simultaneously. I think we really need to address this primary care issue that we have with physicians within our state. So I'm not comfortable with this.
Let me just say a few words more. First, let me express my appreciation for the committee. However we arrive at this outcome, this committee has committed itself to healthcare for Vermonters, and from every point of view, I don't question for a moment the individual commitment that each of you have to having high quality, accessible healthcare for all Vermonters. And I think we've demonstrated in a way, we demonstrate by even our conversation here today and what we've done previously, where there are times when we have come to full consensus in this committee. I think we have a good and proud record of moving initiatives, particularly around prescription drugs, which are very much in my mind, even as we make a decision about this. I went to a meeting yesterday outside the building that had nothing to do, people didn't know I was the chair of the healthcare committee, and yet when I gave someone a ride home, and they said, could you give me a ride? I said, sure. What came up in conversation was healthcare. What came up in what conversation was the unaffordability of their healthcare. What came up was they're having to make decisions about not accessing healthcare to the detriment of their own well-being. And in this particular instance, much to my surprise, they talked about the possibility of having to relocate outside of this country in order to have full access to the health care that they felt they and their family needed. And I was stunned to hear that. I did not know their history, I did not, and this was a spontaneous conversation. I think we struggle. We've made great gains here in Vermont, but we struggle with how to move forward. And at this point, knowing that I don't know what the path for this, for our decision is here today in the building or outside the building, but I'm, at this point, prepared to make a vote that makes a commitment and makes a statement in the direction of universal primary care, because I think it also is a statement toward what I believe we should have, which is publicly financed healthcare. The fact that we have Vermonters whose lives are impacted on a daily basis, who are tied to their workplace, whose well-being is in fact in jeopardy for the very reason that they don't happen to work in a place that has healthcare, good, accessible, affordable healthcare. I think it's our responsibility as the state of Vermont to create every possibility for accessible, publicly financed healthcare for all Vermonters, recognizing the barriers, the difficulties that this particular path creates. So that's, if we do nothing else here today, I'm prepared to use my vote to make that statement, knowing that it's not an easy path, there's nothing easy about it, and recognizing and appreciating the concerns that other committee members have expressed. So. Sure.
Yeah.
And then I think, I'm going to suggest, given the business in front of us, other business in front of us, that we, unless there's a lot more that needs to be said, that we move ourselves toward a vote.
Well, first I want to thank everyone for making your policy statement, because in my motion I was basically asking what is our policy statement, and I feel like people really clearly made that, so I appreciate that. The only thing I wanted to ask, just for clarity for the record, that when the bill passed out of health and welfare, it went to Senate Finance, right? I'm looking at Jen because she could probably answer this. And then it went to appropriations. And my understanding is it was appropriations who amended the bill at the last minute. So just for the record, I wanted to clarify that the bill did make it through Senate Finance without any changes, right?
Jennifer Carby, Legislative Counsel. Yes, Finance approved the Senate Health and Welfare Amendment without recommendation and sent it on to the Appropriations Committee, which is the committee that made the amendment.
Yeah, and I just want to say that because two people said the bill as it came out of Finance.
Yeah, that was my bad.
Yeah, and so I just want to be clear before we vote, like what the process was, that it went through two committees and then was changed. So thank you.
And I realize that there is actually one amendment which I think can be made on the record and not have to wait for a new draft. As I was reviewing this morning, the language, which I had frankly asked to have available, depending on what direction we went, the Senate Health and Welfare Committee version says that the Senate Committee on Health and Welfare may meet up to 5 times. And I don't know why, but I think we should be included in that. I mean, it just seems like, it's a thought. So I would suggest that we amend on the record that in
each instance.
Well,
I think there's two.
I think it's just the one instance in section 3 that we amended on the record to say the Senate Committee on Health and Welfare and the House Committee on Healthcare may meet. And then Jen can assign us, or actually you can tell us what version, will that change the?
Yeah, I'll make it a 1.2.
1.2. Well then, I would hope that you would accept that as a friendly amendment, and that it'd be, your motion would be to adopt draft 1.2 of the version as a substitute amendment.
I think I can live with that.
I know it's tough, but okay. I'd ask the clerk to call the roll.
Copenhagen,
Yes.
Sheena,
Yes?
Dunn,
Yes.
Jinkling,
No.
Gage,
No.
Hebert,
No.
Christensen,
No.
Briglin,
Yes.
Donahue,
No.
Lippert,
Yes.
and Houghton is a yes.
I think the motion carries.
6-5.
Okay, 6-5 vote. Okay, thank you, committee members, and thank you for those who are been having conversation with us from all different angles on this. And, good.